Good afternoon, everyone. We're going to start just a little early so we can get a jam-packed program completed. So welcome everyone to our neuro-otology course. I want to welcome our virtual audience as well who's tuning in online. Please remember to silence your mobile phones. You can access all the program materials from today through the AAN Conference's mobile app, so that should be uploaded. And then translation and transcription services are also available through the mobile app and online platform. To access this, you can scan a QR code that are on the walk-in slides, or you can navigate to the session in the app or platform and click the indicated link. If you choose to use the audio translation option and you're in person with us, please be sure to use your headphones so you don't distract your neighbors. An evaluation must be completed to get CME credit. Those must be completed by May 7th, 2025, and they can be submitted through the conference mobile app as well. And the AAN strictly prohibits all unauthorized photography, audio, and/or video recording of any of the programs. To submit questions, you can submit them online through the mobile app at the Q&A button, and we'll be able to read those up here, or we'll have a microphone so you can come up and ask questions at the end with our Q&A session. So why vestibular neurology or neuro-otology? Dizziness is very common in our outpatient clinics, our emergency clinics, and in other scenarios, and it's a really common complaint that we have a lot of answers for. Most vestibular disorders, fortunately, are clinical diagnoses and do not require special equipment. So this is something most of us can diagnose just by talking with the patient and doing a careful examination. And the other good news is most dizziness has a benign cause, it has a favorable course, and it responds really positively to therapy. So we want to equip you all with better tools to help these dizziness patients. So our course outline is we're going to walk through cases based on your setting. So we'll start in the emergency department with Dr. Daniel Gold. We'll go to the outpatient clinic with Dr. Kevin Kerber. We'll go over some specialty clinic cases with myself. And then we have a special guest today, Dr. Jeff Sharon, who is a surgical neuro-otologist who will give us that ENT perspective of dizziness and when to order special testing. This is all uploaded for you, but I wanted to introduce you to some really helpful resources for clinicians that you can take a screenshot of, or this is all uploaded in the app. And then we have resources for patients. This can be super helpful as well, so they can have some really high value education available to them. All right, so I'm going to turn the time over to Dr. Dan Gold. While we're bringing up his slides, a reminder to anyone in the room, we have active vestibular neurology fellowships, so please come and talk to us after the fact if you have any interest in that future.
All right, can you hear me in the back? Everyone, thumbs up? Yeah, perfect. Okay, so after my talk, I have to give another talk in another session and then come back, so I'm not storming off. I'll be back, and I'm excited to answer your questions if there are any. So first, I just want to give a plug for the new continuum issue. It's on neuro-ophthalmology. If anybody's interested in nystagmus eye movements, I did that chapter as well, if anybody's interested. But here I'm going to talk about acute vertigo. Which of these do I need to click? Okay, I'll use this. Everybody's favorite. I have no disclosures relevant to this talk. So basically, we're going to talk about what you're most likely to see in the emergency department setting when it comes to dizziness and vertigo. We're going to talk about the HINTS exam. There are limitations to any exam. In the hands of subspecialists, hopefully by the end I will have convinced you that it's a great test, but that anybody can be a specialist, subspecialist, and become an expert in the HINTS exam. And so the vast majority of dizzy balance patients can be diagnosed accurately at the bedside with a good history and exam. It takes some time. What should we be doing first and foremost? We shouldn't spend 35 minutes with an 80-year-old patient at 2 a.m. trying to understand what giddiness means to them. Instead, we should take a triage titrate test approach to this. Pick the lowest hanging fruit. Is this medication related? Is this medical? Is this an acute stroke? Certainly you wouldn't want to hold up the administration of TPA. Titrate. We're going to talk about the timing and triggers and targeted exam, and then we're going to decide what to do next. So this is the approach that we should be taking when we're taking the history in the emergency department. Two patients you will encounter, whether you want to or not, they will find you. Number one is a patient who has BPPV, positional vertigo and nystagmus, that is triggered by head movements. The patient's not sitting there continuously vertiginous with the eyes jumping. You have to trigger it. And they will present by symptoms triggered by looking up, down, rolling over in bed, going from lying to sitting, sitting to lying. And the Dix-Hallpike works beautifully. And the supine roll test, if there's a horizontal canal variant, works beautifully. Patient 2 that we're going to talk about is the acute vestibular syndrome. These patients are continuously vertiginous, continuously have spontaneous nystagmus, and you will absolutely aggravate their symptoms and the nystagmus by doing a Dix-Hallpike, but that does not equal a positive Dix-Hallpike. And so this is unprovoked, continuous vertigo, nausea, vomiting, spontaneous nystagmus. So you're looking at them and the eyes are jumping and jiggling, imbalanced head motion, intolerance. And the Hintz exam works beautifully for this patient, not for patients with BPPV, for this patient. And so I'm here to tell you that Hintz and Hallpike work really, really well if the exam maneuvers are applied appropriately. So doing the Hintz exam in the acute vestibular syndrome, you can even think of it in your head as the AVS Hintz exam. Hallpike in BPPV, and properly performed. I know how to do the head impulse test. I know how to do the Dix-Hallpike. There's a clinical skills session tomorrow if you're not sure how to do these, the head impulse test, the Dix-Hallpike, so please come to that. And the results are interpreted correctly. This is a peripheral Hintz. This is right posterior canal BPPV. But what happens, and I've been guilty of this, hopefully not for the last couple of years, exam maneuvers are applied inappropriately. So the Hintz exam is applied to a patient with episodic vertigo that's triggered, that's BPPV. Or somebody does a Dix-Hallpike in somebody with AVS, the acute vestibular syndrome, the patient throws up on their shoes and they say that's a positive result. Or improperly performed. You're not sure how to do the head impulse tests, or misinterpreted. There's right-left confusion, this is peripheral when it's actually central, etc. So it's not just me saying that the Hallpike and Hintz exams work well. These are the guidelines, the GRACE 3 acute dizziness and vertigo in the emergency department consensus guidelines that were created by David Newman-Toker, among many others in the emergency medicine world. And these were their conclusions. In patients with nystagmus, trained clinicians should use Hintz testing to distinguish central from peripheral with a high certainty of evidence. Use the Dix-Hallpike test to diagnose posterior canal BPPV. This is what we should be doing. However, what does trained mean? And who is training people to do this, right? That's sort of the million-dollar question, and how are we supposed to train the next generation? That's easier said than done. But anybody has the ability to be the world's expert in Hintz, I promise you that. So a little Hintz history. So in 2009, David Newman-Toker, Dr. Katan, others initially described the Hintz exam, and that Hintz is better than MRI diffusion-weighted imaging in the acute vestibular syndrome. And Hintz Plus, adding hearing, assessment of hearing, works even better and is more sensitive than Hintz in the acute vestibular syndrome. And we know that we should be looking for truncal and gait ataxia in these patients as well. So is there one algorithm to rule them all? Not really. One of my mentors recently said that the standing algorithm is essentially Hintz and Hallpike, but without any thought. Because you're not asking any questions. You're just indiscriminately doing everything in every patient. But what about a patient who has a stroke and happens to have BPPV? So this could do harm potentially. Is there a score that we could use that applies to everyone? Not really. There have been some studies coming out, the Sudbury vertigo risk score. And I think the biggest problem with this, among others, is that the BPPV diagnosis is going to take away 5 points, but who's making that diagnosis and with what degree of confidence? How many of those patients actually have BPPV? So patient number 1, BPPV. I'm not going to talk about the treatment. You can find that in my collection. Lots of other great resources out there. How to do the Epley and the barbecue roll and the Gufani and things like that. So I'm not going to talk about that, but they're here. if somebody is interested in kind of one-stop shopping. Pause for photos. All right, you don't have to take your camera out if you didn't want to take a picture, but all right. So you don't have to ferociously slam the patient down like you just saw here, but this is a really nice example of exactly what we absolutely have to see to diagnose right posterior canal BPPV with confidence. In a right Dix-Hallpike test, you see and trigger an upbeat torsional nystagmus towards the bottom lowermost ear, the right ear, the affected ear, and that's due to otoconia floating around in the posterior canal. This is what you must see. There's a little bit of a latency, a couple seconds, upbeat torsion towards the affected ear. It's crescendo, decrescendo. Also consider orthostatic dizziness when the patient only experiences symptoms when going from lying to sitting. However, somebody who has orthostasis isn't going to have symptoms triggered if they roll over in bed, or if they go from sitting to lying down, for instance. If you don't have fancy goggles, and a lot of patients just don't have as robust a response as that first patient you see, you might predominantly see some torsional movement. So pick your favorite conjunctival blood vessel, and you can see a right Dix-Hallpike, top poles of both eyes beating towards that right ear. If the patient's fixating, if you're not using Frenzel goggles, for instance, then the vertical component might damp a little bit, and it might look like there's more torsion than anything else. And if it sounds like BPPV, but everything's normal, there's no ocular motor dysfunction, there's no neurologic impairment on your examination, and it sounds like BPPV, try it again. Do another Dix-Hallpike. Have them come back and see vestibular physical therapy. What about horizontal canal? We've got 3 semicircular canals on each side. So if the otoconia, the crystals are moving in an inhibitory direction, you're going to see in this patient who has a left horizontal canal BPPV going in the inhibitory direction, and now they're going in the excitatory direction. Same crystals, same canal, just moving in 2 different directions. First time inhibitory, now excitatory. This is geotropic. It's beating towards the ground, towards the earth in both conditions. And when you see geotropic positional nystagmus, that's almost always peripheral. And so if you have geotropic beating towards the earth, you're probably going to have the opposite of that, apogeotropic. So here, the right ear is down and the patient has left beating nystagmus. And as a general rule, regardless of kind of, to keep it straight and to diagnose the correct ear, when the nystagmus is strongest, it's going to beat towards the affected ear. So the right ear's down, it's left beating. And I'll tell you that when his left ear is down, there's more right beating. And so this is going to be a right horizontal canal BPPV. Sorry, I can't go ahead a couple seconds. Apogeotropic is usually peripheral, but there are exceptions. And you should be a little bit more concerned about apogeotropic versus geotropic. And just making the point, left ear down, the right beating is strongest. When the nystagmus is strongest, it's going to beat towards the affected ear, which is the right side in this case. This is a patient I saw, this is a pretty extreme case, who presented with positional dizziness. And she's got a little bit of downbeat in addition to right beat. The left ear is down towards the ground. So this is apogeotropic. And when the right ear is down, right supine roll test, there was left beating, so apogeotropic, and this is the first manifestation of kind of a full-blown cerebellar syndrome in the setting of CJD, and this patient passed away a couple of months later, rather. This is another patient who presented with apogeotropic nystagmus, positional nystagmus, who had a cerebellar midline tumor. So you should be a little bit more concerned about apogeotropic. And then there's downbeat. So what happens when you see a downbeat torsional nystagmus? Here the top poles are beating towards the left ear. Is this a posterior canal variant where the crystals are moving in an inhibitory opposite direction and causing downbeat torsion instead of upbeat torsion? Is this in the anterior canal? It's hard to get crystals into the anterior canal and for them to stay there for long enough. Or is this something that's central? And so if you do a Dix-Hallpike, this is kind of a straight head hanging maneuver, straight back, and she had the same response, right, left, Dix-Hallpike, straight back as she is here, and there's just a pure downbeat nystagmus that doesn't fatigue, you can't predict it based on the canal that should be involved. It doesn't fatigue, as I said, no response to repositioning maneuvers, and she had other neurologic abnormalities in coordination, gait, and stance, a little bit of downbeat in lateral gaze, and these are red flags, as well as oculomotor abnormalities. So if you're not sure, phone a friend or have a low threshold to get an MRI in these patients as well. Patient number 2, I'm going to spend the rest of the time talking about the acute vestibular syndrome. And about 80% of the time, we're talking about something peripheral, vestibular neuritis. This is an upbeat torsional nystagmus, but this is the wrong syndrome. This is not a patient in whom they have triggered nystagmus and dizziness. This is not a patient who has a BPPV history, but rather a patient who has an acute vestibular syndrome history. And so they're continuously vertiginous, and the eyes are continuously doing this for hours and hours and days. So that is not BPPV. This is the acute vestibular syndrome. And if it's vertical or torsional, as it was here, vertical and torsional, then that's not a peripheral pattern of nystagmus. So what is the right test for central acute vestibular syndrome? It's definitely not a CAT scan, where you're going to miss about 90% of acute vestibular strokes. An MRI is way better, but it's been shown that in the first 24 to 48 hours, you might miss up to 20% of the time little strokes occurring in the cerebellum or the brainstem. But it's been shown that a specialized eye movement exam, the HINTS exam, is much better than both, with a sensitivity and specificity to detect a central etiology that is much higher than an MRI DWI as well. And so these GRACE 3 guidelines, what do they tell us? In patients with or without nystagmus, do not routinely use non-contrast brain CT or CTA with a high certainty of evidence. In patients with or without nystagmus, do not routinely use MRI or MRA as the first-line diagnostic test if a clinician trained in HINTS is available. And so what is the HINTS exam? So this is one of our fellows now on faculty at Johns Hopkins, Dr. David Hale, and this is what it is. Head impulse nystagmus test askew. And I like to kind of warm the patient up with some head movements. Typically in the emergency department, when there's spontaneous nystagmus, it's not a bad idea to start out to the right or to the left and end in the middle. That way you don't have to worry about that Alexander's law nystagmus, where there's a lot more nystagmus in the direction of the quick phase, so that if you do a head impulse test on somebody who has acute right-sided vestibular neuritis, they have left beating. What happens if you turn their head to the right to see if there's an abnormal head impulse test to the right? The patient's looking at you to the left where the left beating is maximal. Then it can be hard to decide whether you're seeing a quick phase of the nystagmus or a catch-up saccade. And this is what it is. It's quick, it's easy, and if it's clearly central, if there are any central signs, then you're done. You got to do a little bit more work to prove that it's peripheral. We'll talk about that next. The HINTS exam is validated in the first 72 hours, but it's still really important and works well weeks to months later in a lot of these patients. What is the basis for the HINTS exam? We're just essentially taking our knowledge of the labyrinth, the semicircular canals, the angular acceleration detectors that stabilize our vision when our head's in motion. And we're looking for any imbalance. We're looking for dynamic imbalance in the canals horizontally. Is there an abnormal head impulse test? We're looking for static imbalance. What happens if there's static imbalance? We're going to see spontaneous nystagmus. And then what else do we have? We have the otoliths. These are the linear acceleration detectors, which also respond to tilting the head. And so we're essentially just looking for static otolith utricle imbalance if there's a skew. However, if there's a peripheral skew, if you affect those utricle pathways or the utricles peripherally, you tend to have a very small skew. If you affect those pathways centrally, oftentimes you'll have a very large skew that must cause diplopia in a patient who has bilateral vision, right? If they are blind in one eye, they're not going to see two. And so what is the pattern? The only acceptable pattern for a peripheral HINTS exam, you must see an abnormal head impulse test. And if you have an abnormal head impulse to the test to the right, then you're going to see a spontaneous left beating nystagmus. So this would be the example of a right-sided vestibulopathy, right-sided vestibular neuritis. And you have to have a normal test of skew. Here you can see that this patient has a little bit of a horizontal deviation. The right eye comes in, the left eye comes in, but that's not a skew. There's no such thing as a horizontal skew. A skew is a vertical misalignment, okay? But for you to be confident that this is vestibular neuritis, this is a peripheral hints, all of these must be present. Not one, not two, but all three. All of them. No exceptions. Each of them must follow a peripheral pattern. So what does it look like in the emergency department? These are two patients who have a spontaneous right beating nystagmus. Oftentimes you're going to see that it's a little bit mixed horizontal and torsional. Even looking to the left, it's still right beating. There's still a little bit of torsion, top pulse towards the right ear. And then you have the patient look in the direction of the quick phase, and there's clearly more in accordance with Alexander's law. This is what you have to see. If you see anything other than this pattern, then it's central until proven otherwise. And also, I would just add at the bottom there, if spontaneous nystagmus isn't present, then it's not acute vestibular neuritis, right? If the onset was a couple hours ago or a day or two ago, that asymmetry, that destructive acute lesion is going to create a lot of asymmetry, which causes spontaneous nystagmus. If you don't see spontaneous nystagmus, you cannot be convinced. And here's just a nice way to bring out, some patients have a rip-roaring vestibular nystagmus, some patients don't. This is a patient where we used a pen light cover test. You can see us lurking there, our reflection. But what we're doing is kind of blinding her with the bright light from the pen light, covering the other eye. So we're partially removing fixation, and we're able to bring out her spontaneous left beating nystagmus. It's a little bit clearer to see. So that's a quick and easy tool. And this is a patient with vestibular neuritis 1 week ago. There's no spontaneous nystagmus, but again, pen light cover tests, removing fixation. She's got a little bit of right beating. And still she's got right beating and right gaze, but not straight ahead. But you must also see this abnormal head impulse test. And every time the head is turned to the left, you see these catch-up movements. The eye moves with the head to the left, and then there's a catch-up after each of them. We use video head impulse tests, which is great. We can not only see those saccades that we see at the bedside when we do a head impulse test, but we can also measure a gain. On the good side, the gain is 0.99. On the bad side, it's 0.26. This is the ratio of the eye movement velocity to the head movement velocity, which should be 1, which it is on the good side. And we can see a couple of measures that tell us that this patient has vestibular hypofunction on the left side. And just a couple weeks later, this patient also has an abnormal head impulse test on the left. You can kind of see it there, but it's really much more subtle than it was acutely. This is another patient, and some patients just compensate really quickly. So if a couple more days go by within the sort of 72 hours where the hints works really well, over time it gets harder and harder and harder to clearly see the central or the peripheral manifestations via the hints exam. And this is in slow motion, just making the point that this is a patient who compensated really well, and you can just barely see the teeny tiny little catch-up. But when we did video head impulse tests, we see that she's compensated so well that she's making all of her corrective saccades, corrective eye movements, during the head impulse itself. So these aren't really detectable at the bedside unless you have a high degree of suspicion, unless you really sort of change up the amplitude, which works well. But the video head impulse test is a great test for this as well. These covert saccades can make the hit look normal. And what about central hints? Like I said, it's a little bit easier to say this is probably central versus peripheral. You just have more work to do when it's peripheral to prove that it is in fact peripheral. So spontaneous nystagmus should be present, and a central AVS, acute vestibular syndrome pattern, would be a normal head impulse test, right? You're sparing these peripheral, the vestibulo-ocular reflexes. And so if that's the case, then we're thinking about something central. If we don't see that perfect mixed horizontal, torsional, unidirectional increases via Alexander's law, pattern nystagmus, anything other than that should be central until proven otherwise. This is a patient who had Wernicke's encephalopathy, who had spontaneous upbeat and gaze-evoked nystagmus in all directions. So this is central, central, and more central. And if a patient has vertical diplopia that's new, then you're very concerned right off the bat. But this is an abnormal test of skew. You can see a big vertical deviation, and this is a skew deviation. But like I said, if a patient has vision in both eyes, they're going to see two. They're going to experience vertical diplopia. And here, again, it's a little bit easier because if any of them follow a central pattern, you got to get an MRI. You got to assume that this is central until proven otherwise. And it's a 3-step test, not a 1-step test. So if any of the steps look central, you're done. All of the steps must be peripheral in order for you to be reassured. And what about the HINTS Plus exam? We should also be assessing auditory function at the bedside, checking via finger rub. We should be performing otoscopy. Is there a bacterial labyrinthitis? Is there Ramsay-Hunt looking for vesicles? And if otoscopy is completely normal and the patient has deafness on the same side as their vestibular loss, you should consider the possibility of a labyrinthine ischemia, right? The basilar artery supplies the anterior inferior cerebellar artery, which supplies the internal auditory artery. So when you have a labyrinthine stroke, almost always, not 100% of the time, but you're going to have cochlear ischemia, which is going to cause ipsilateral hearing loss as well. And so if we add this 4th step, the HINTS Plus exam or test, then the sensitivity for detecting central etiologies is going to increase even more than the 3-step HINTS exam. And cool off the press, it was hot off the press a couple years ago, and last year it was warm, and now it's cool. In patients with nystagmus, assess hearing by finger rub to distinguish central from peripheral diagnoses. So what if the eyes aren't jiggling? So you gotta walk the patient. You have to sit them up, right? You have to look for truncal ataxia. Can they stand independently? If they can't, that's a big red flag. And you've got to walk them as well. And the degree of gait ataxia is going to be a big indicator. Certainly truncal ataxia, can't sit up, can't stand up, big red flags. And if they can't take even any steps without minimal assistance, then you're pretty concerned about that as well. And if the eye movements are normal, the general neurologic exam is even more important, especially gait and stance. And cool off the press, in patients without nystagmus, assess severity of gait unsteadiness to distinguish central from peripheral diagnoses. And so what about TIA? The problem with this is that usually by the time you get to the patient, their episode has subsided, right? So you really have to rely on the history. You have to rely on risk stratification, ABCD2 or other scores. You should still examine the patient and do HINTS, but you can't solely rely on the rules of HINTS in a patient who's not symptomatic. And what about stroke? Again, patients with cerebellar strokes can have vertigo, imbalance, and normal eye movements. So we've got to rely a little bit more heavily on gait and stance in the general exam in addition to risk stratifying. What if the patient has a headache? So the frequency of headaches in stroke is about 27%. We know that it increases with posterior circulation strokes, and headaches are usually severe with posterior fossa hemorrhage. This is a pretty rare cause of the acute vestibular syndrome in the absence of focal findings or a severe headache or change in mental status. But if, especially in a younger person, in addition to their acute vestibular syndrome or any vestibular symptoms, they have sudden sustained severe head or neck pain, you should be very concerned about the possibility of a dissection, a vertebral artery dissection. So do not forget about that possibility. All right, patient 3, anything that's not AVS or BPPV. Lots of migraines. You're going to hear about migraine. I'm not going to cover migraines, just making the point that it's not uncommon for a patient with vestibular migraine to come to the emergency department. It's impossible to make a clear and consistent with 100% certainty diagnosis of vestibular migraine if it's one single attack. And just making the point that nystagmus in the setting of vestibular migraine can kind of be anything. It can be horizontal, it can be vertical, it can be upbeat, it can be downbeat. But unless there's a long and strong migraine history, assume that your acutely dizzy patient with headaches has a dangerous cause until proven otherwise. Consider, and I put this in italics, consider Meniere's, and generally speaking, and this is a great study, Vestibular Event Monitor, they sent patients with these known diagnoses of Meniere's and vestibular migraine and BPPV home with these cheap goggles, event recorders, and they pushed a button and recorded their eye movements during attacks. And what do we know about Meniere's? Typically, they have a pretty high velocity horizontal nystagmus, much more high velocity than what you see in migraine typically. But be concerned by sudden deafness without a clear Meniere's history. And again, consider the possibility of labyrinthine ischemia. You cannot make a diagnosis of Meniere's with one single episode when you're seeing them in the emergency department. All right, diagnosis of the spontaneous episodic vestibular syndrome. So what should we be doing? Exam, being good neurologists. We should not be using a CAT scan to distinguish central from peripheral. If you're concerned about TIA, we should be doing vascular imaging as well, which all that makes good sense. And in the last 2 minutes, just a few other little ocular motor findings that can be helpful. And all this and much more can be found in this paper. But we should do head shaking. We should do it at the end of the exam because these patients, it will make them feel worse, and they might throw up on your shoes. But you want to do this after the Hintz exam, after Hall-Pike, after everything else. And essentially, this is bringing out vestibular asymmetry, if any is present. And this is the only acceptable peripheral pattern. So this is a patient with a Ramsey-Hunt on the left, vestibulopathy months ago. And so what should it do? You should have a contra-lesional nystagmus, slow phase drifting back to the paretic ear. That's the only peripheral pattern that is acceptable. What if you have no vestibular loss? The head shaking induced nystagmus is too strong. Robust head shaking nystagmus without any vestibular loss. You should be concerned about something central. What if you shake the head horizontally and you see cross-coupling? So a vertical response, downbeat, that's caused by horizontal head shaking, that is a central sign as well. Or what if a patient has spontaneous right beating nystagmus and you head shake and it's left beating? It reverses. It's in the wrong direction. If you see a reversal, then this is a central pattern as well. Okay? You should also have them gently close their eyes and see if the eyes veer in one direction under closed lids. This patient has a Wallenberg syndrome on which side? On the right side, absolutely. So the eyes are going to drift toward the side of the Wallenberg lateral medullary lesion, which is usually a stroke, and then the patient opens their eyes and makes hypometric saccades back to center. Very quick and easy little test. And I will skip over pursuit, especially since it's blinking. And final pearls, recognize when it's the AVS and use hints. Call it the AVS, hints to keep it straight. Aggravating dizziness during the Dix-Hallpike does not make it a positive test. Don't overemphasize the general neuro exam. Don't underemphasize the oculomotor exam and the acute vestibular syndrome. And if you don't see this, abnormal head impulse test and unidirectional nystagmus and negative test askew and no hearing loss, then you should assume that it's central until proven otherwise. Upbeat torsional or geotropic nystagmus is almost always indicative of peripheral BPPV, but be a little bit more concerned about apogeotropic and downbeat nystagmus. Thank you so much.